Welcome back from the networking break, everyone. And next up, we've got a great session lined up for you, all about AI, and that's with Angela Yochem. She is EVP, Chief Transformation and Digital Officer at Novant Health. Now, you've probably heard of Angela before. Angela has served as EVP, CIO at Rent-A-Center, Global CIO at BDP International, Global CTO at AstraZeneca, and Divisional CIO at Dell. She's held various tech roles, exec roles at Bank of America and SunTrust, and held senior technology roles at UPS and IBM. In these roles, Angela built B2B digital product lines, grew digital retail channels, B2C, created technical service lines of business, and transformed global technology capabilities. Angela is an independent director with Zurich American Insurance Group and has been a director for the Federal Home Loan Bank of Pittsburgh, BDP Transport, BDP Global Services Asia and Europe, and Rakana, with experience on audit, enterprise risk, operational risk, and governance policy committees. She remains an entrepreneur in residence, mentor, and advisor for venture groups and incubators on both US coasts. So, very pleased to have her here today, and welcome, Angela.
Thank you, Scott.
Now, Angela, I think the topic of today's conversation is going to be transforming health and wellness, what industries can learn from health and systems using AI. And of course, we can't talk about health and wellness without mentioning that dreaded COVID-19. So why don't you just tell us a bit about the impact of COVID-19 from your sense? And in healthcare, we saw some transformative innovation, like dramatic adoption of telehealth. So tell me more about that.
That's an excellent point. You know, when people ask me about the COVID-19 pandemic and whether it triggered new technology investments for us at Novant Health, or if it, allowed us to create digital channels by which our patients and team members can access services, I'm always quick to say that we already had a robust digital health capability that supports advanced diagnostics in the patient's homes or other unconventional venues of care. We were already strong users of collaboration tools like Teams and Zoom and DocuSign and others in support of our highly distributed workforce. And we already had a strong enterprise information management capability and cognitive computing team and so on. And we even already had a drone program. Although during COVID, we were cleared to operate like an airline for emergency use. We were just not one of those systems scrambling to figure out how to operate in the world in which we suddenly found ourselves. So we had that. That said, we did see a remarkable increase in the use of digital health services, in the use of collaboration tools. We saw a significant change in the regulatory appetite for new modalities of distribution, in the payer appetites for reimbursement for certain types of care. And I think those appetite changes and those new routines and cadences will stick around. Our experiences over the last year and a half have changed the way we think about treating the whole patient in a seamless and multi-channel, holistic sort of way. We're now basing our future planning on actual data rather than supposition and projections. It's such a luxury. But, all of that's not so much about technology innovation, although there were certainly tech solutions behind the scenes. And I'd love to talk about them here today. We also made big strides in health equity in the past 18 months. And I think it's important to understand that we used our advanced analytics to identify gaps in vaccine access for all of the communities that we serve. And it's that sort of analysis that prompted us to find unconventional ways to reach those members who were most at risk. And as a result, we're hosting community pop-up events to reach minority populations, administering, tens of thousands of doses. I think 71% of our attendees at these community pop-up events identify as an ethnic minority, and our vaccination rates for Asian and Black patients at the community events is 3 times that of our state vaccination rate. So these are simple examples of how we've addressed the COVID outbreak in ways that are very precise, not a one-size-fits-all sort of approach. But it's the same sort of underpinnings and foundational capabilities that will allow us to advance wellness and value-driven care, not just sick care. And by value-driven care, for your audience sake, I mean things like preventative care, screenings, other vaccinations, all of the things that overall impact the general health and wellness of our communities for all populations. So in that sense, we did see a significant expanse as a result of COVID-19.
You mentioned there at the beginning of that answer, talking about how there was this digital transformation and how healthcare was suddenly far more reliant on data. Is there an argument for saying it should have been far more reliant on data to begin with?
100%. One of the things, as part of the introduction, you mentioned that I've had the opportunity to serve across a variety of industries in the same sort of role I have today. And that opportunity has afforded me the chance to see the difference in constraints that exist across a variety of industries, the ways in which regulations apply across a variety of regulatory bodies in the respective industries that they oversee. And when I joined Novant Health about 4 years ago, I was interested to learn of the various regulations that constrain or that were perceived to constrain how healthcare systems are allowed to operate on clinical data and other behavioral data of interest that perhaps the retail industry, for example, is not as constrained in. So I think one of the learnings, and the other thing I'll tell you about healthcare is that there has been historically a reliance on very large electronic medical record vendors. And if you think back 20 years ago, 15, 20 years ago, to what the big ERP vendors used to look like, for those of you who have been around that long, remember how, 15 years ago, businesses couldn't get their hands on their own business data because it was captured inside of a closed proprietary system, and access to that data could only go through the interfaces provided by that system. Not to name any names, I'm sure everyone is already naming names in their heads. But over time, those large vendors recognized that those sorts of closed platforms were ultimately very constraining. And the vendors that have continued to thrive in today's world are those that opened up their platforms and allowed for businesses to operate on that business data to serve their own purposes. And likewise, we're seeing a similar expansion in the EMR community. So the EMR vendor community has historically been, up until relatively recently, much of the same mind that those ERP vendors were 20 years ago. So they're just now opening things up so that healthcare systems like ours can get the hands on the data, the clinical data that sits behind their systems. So we were able to, about 3.5 years ago, we liberated our data from our clinical data from the EMR, and we host it in a highly secure cloud-based environment, in front of which we have a robust API layer that allows us to access our clinical data and operate on it in ways that give us tremendous power when we think about doing things like predicting major health events before they happen for individual patients and changing the way we engage with those patients as a result, changing the way we think about preventative medicine for those patients, and many, many other sorts of things we're able to do with that data, especially when you think about it in the things we can do with it in concert with a bunch of other behavioral data that comes in from a variety of sources, or streaming data that come in from various wearables that our patients have hooked up to our system and the like. So yes, it is something that should have been going on for many, many years. We were fortunate here at Novant Health in that we were already ahead of the curve. As I mentioned, we've established a very strong enterprise information management capability set and a strong cognitive computing team. And I'd love to talk to you more about some of that detail as we sit here today and talk. But yeah, I think in fairness to the healthcare systems, it's not that the leaders didn't know that they should be doing it. It's that there were very real constraints preventing them from being able to leverage capabilities we see in other industries.
Yeah, of course. Yeah, I understand that. Okay, so let's talk about some examples then of how you can leverage AI and advanced technology to actually make healthcare better. What is it that you are doing?
Well, I have to tell you, I am very fortunate in that I have a partner in our Chief Medical and Scientific Officer, Dr. Eric Eskioglu. He's a practicing neurosurgeon, and incidentally, in addition to being a brain surgeon, he's also a rocket scientist. So he used to be an aerospace engineer. So this is no dummy. He's a great partner to help me as we have founded and continue to run what we call our Institute of Innovation in Artificial Intelligence. So about 3 years ago, we co-founded this institute. And as part of the construct, we created a set of routines and boundaries that allow for the rapid discovery and development, experimentation, and ultimately deployment and adoption of advanced technologies of all sorts into our environment. And as you can imagine, many of those advanced technologies are powered by AI-based models and algorithms. So we work with thought leaders from across our enterprise and also throughout our robust ecosystem of partners to identify and deliver those remarkable solutions that allow us to expand access to care and improve quality of care. And by the way, those are the two things that we always keep top of mind. It's always about expanding access to care so we can provide care to more members of the communities who might not otherwise have access, and also to continue to improve the quality of care. Our quality scores by all industry benchmarks are remarkably high, but we still want to improve quality. And so when we think about quality of care, and I'd ask everybody who, all of the technologists in the room to think about this, we try to find solutions that will get us to a faster diagnosis and a more targeted, personalized treatment, which of course lead to, better outcomes for our patients. So faster diagnosis, what does that mean? That means you need a very granular level of data. You need to be able to analyze that data. You need to be able to predict outcomes or predict and potential outcomes, and then prescribe behaviors and actions to take to prevent negative outcomes and promote positive outcomes, right? These are the data geeks in the audience are getting excited, right? When you start thinking about those sorts of things, how would you solve problems like that? I'll give you some examples. So a great example of a solution along these lines is the Viz AI platform for stroke care. So I'll tell you how that came about and how our background infrastructure supported the capability. But first, let me tell you what it is and what it does. So we are located in the southeastern United States. We serve 5 states. We are in what is known as the stroke belt. We really like our fried foods, and we just have a lot of stroke patients in our geography. What typically happens in the U.S. when you have a patient who's exhibiting stroke symptoms, they are typically delivered to the emergency department, the emergency room. The emergency department assesses them, says, oh yeah, you're exhibiting stroke symptoms. And we immediately rush the patient back behind the scenes and put them in a CT scanner. Because if they're exhibiting stroke symptoms, we need to get a picture of their brain. We need to understand if there is a brain bleed, or a blood clot in their brains. So we quickly put them in the scanner. Now, what I'm going to describe to you is what happens, generally speaking, in most hospitals. We have vastly improved, and that's the purpose of my story. But what I'm going to tell you is the standard procedure. So the patient goes into the CT scanner. The brain scan is complete. Once the scan is complete, the scan is reviewed by the radiologist on call. The radiologist on call looks at it and says, that does look like a brain bleed. Let me pass it to our physician on call. So then the physician on call takes a look at it, says, yep, that looks like a stroke. That looks like a brain bleed. Let me get it to the neurosurgeon on call. So then the neurosurgeon on call takes a look at it and says, yep, that's an operable occlusion. We need to get in there. We need to remove that clot. The neurosurgeon orders the operating room to be made ready. The neuro team is called. The operating room is set up. And the patient is finally wheeled into the operating room after being prepped for surgery. And ultimately, the brain bleed is removed. The occlusion is removed from the brain. Now, that's standard. And the average amount of time it takes in the US between the time when the patient shows up at the emergency department and the time the occlusion is removed from the brain, on average, is about 55 minutes. So most everyone knows that in strokes, every minute counts. And so I think you lose 1 or 2 million brain cells a minute. Now with the Viz.ai solution, here's what happens. When a stroke patient shows up in our emergency department, we put them in a CT scanner to take a picture of the brain. But what happens now is that as the data is being collected before the image is complete, it is immediately shared with a cloud-based solution by this partner, Viz.ai. It is analyzed using AI-based algorithms such that they can complete the image before the image has actually been completed in the CT scanner. They can identify an operable occlusion. Immediately at that moment, they notify the neurosurgeon on call through a corresponding app in the neurosurgeon's phone. The neurosurgeon can see an image of the brain that has been completed by the AI-based solution. The occlusion is identified, and with a click of a button on the app, the neurosurgeon can get the OR ready. So we have pulled patients out of the CT scanner before the scan is even complete and taken them straight back to the OR. And the amount of time that we now see patients, the amount of time between the time the patient shows up to the emergency department and the time when the occlusion is removed in our hospitals has been as little as 14 minutes, and on average is about 22 minutes. So just life-saving, life-changing. Now, the other thing I'll tell you, and this is where I think people can perhaps take some learnings from it, because not everyone's treating strokes, right? You're in different industries. You don't care about strokes. Hope you never have to care about strokes. The thing that's interesting is from the time we learned of the existence of this solution that is commercially available through Viz.ai to the time that we had it in all of our hospitals was 4 months. Now, we're a big organization. We're about an $8 billion organization. We have 37,000 team members. We have 800 plus locations. We have 17 major hospitals. We're not a small mom and pop shop. So 4 months is kind of a big deal. For anyone working in a large IT shop, you get that. So I want to tell you what made that possible. We initially became aware of the solution through our CFO, who was looking at it as an early stage investment. Our chief medical officer, whom I mentioned earlier, was thrilled to hear about the solution, pulled in a small team through the Institute of thought leaders in radiology, in neuroscience, our operations team, because the process that was being impacted was part of the ED, and then of course our digital teams. And we very rapidly pulled together an experiment with the vendor, with the partner, actually learned from the process, did some mock runs, and with no actual operations happening, but some actually gathered data of what that would look like running in our environment. And then we made the decision to move forward with the benefit of that data. So it was a great scouting story. It's a great experimentation story. And then a great adoption story. And that is the constructs that we put in place in the Institute to allow for this rapid evaluation. That's why we were able to go from start to finish in 4 months. 4 months is shorter than most enterprise sales cycles, right? So I don't have to tell that to any of the enterprise software companies in your audience, but it's important for companies like ours and for any fast-moving, forward-thinking company to have the capability to move fast.
And obviously, sorry, I've just put in here. So obviously, the AI did some amazing work there in terms of being able to accelerate that whole process from, I think you said it was like 55 minutes on average down to 22 minutes on average. And
on average,
that's potentially life-saving, right? And it can be it can be better than 22 minutes. Absolutely. How important is it to retain that human element in that process? So like you said, it does go to I think it goes to the neurosurgeon, I think you said, and they
That's
also
right.
make the decision based on the data. So it's because this is something that's often leveled at AI, isn't it? Is that it's there to replace people, but clearly it's not, right? It's there just to make it more efficient and to improve the process.
There's a great quote floating around out there. Our chief medical officer says it all the time, and that is, it's not that physicians will be replaced by AI. It's that physicians who don't use AI will be replaced by physicians who do. And it's a tool set that allows for faster diagnosis, more personalized treatment. Why would you not apply that in your practice?
Yeah.
There's another, when you think about the human element. There's another solution. That was an off-the-shelf solution. I'll give you one more off-the-shelf solution. In other words, commercially available solution that we have adopted, and provide that as an example. But I definitely want to go into some things that we've created from scratch or co-created with other solutions, other partners in our ecosystem as well. But the human element, when you made that comment, it reminded me, I wanted you to hear about something we did that was rather bold last year, or 2 years ago now. We built in Charlotte, North Carolina, we built a fancy new cancer center. I mean, it is a gorgeous building. It's glossy. It's multi-story. It overlooks uptown Charlotte. It's stunning. And we were so bold as to build that. We have a floor that's dedicated to infusions, an infusion center, and we built that infusion center with no waiting room. So if you think about the experience of a cancer patient, and I hope that nobody in this audience ever has to know what that is, but cancer treatments are typically administered through an infusion, which means that it is essentially like an IV. And the infusions are typically administered over the course of an hour, give or take. Maybe a couple of hours. These are slow drip sorts of things. So a patient receiving an infusion would come into what's called an infusion chair. It's connected to the IV stand. You can administer multiple medicines. It's typically a very comfortable chair. We have smart chairs, and I'll get into that in a minute. And you try to make the environment as calming as possible. Our infusion center in this new cancer building has, floor-to-ceiling windows, great views. I mean, it's just a beautiful spa-like setting, but no waiting room. And the reason we did that is because when a patient typically comes to the cancer center, they probably have an appointment first thing with their oncologist. They probably sat in a waiting room as they waited for their oncologist to see them. Then they may have had an appointment with their hematologist, and they sat and waited in a room a little bit longer. And the last thing we want them to do is have their last stop of the day in the infusion center to also involve a waiting room. So we use essentially, for your computer scientists, if you ever took, CS 150, one entry-level computer science class, you may recall writing your first scheduling algorithm. This is that on steroids. So you have, we have an AI-based, very flexible, reactive a solution that takes our patients as they walk in and immediately assigns them to a chair. It's a scheduling capability that allows us to give patients very precise times for them to walk into the infusion center. So they can, instead of coming to the infusion center and waiting, if the chair's not going to be ready for 7 more minutes, they can go, grab some water. They can stop by the ladies' room or the men's room, whatever. They can, or the non-gender specific bathroom, and they can walk down to the infusion center at the exact moment they will be led back to a chair. So it gives us a degree of precision that I think significantly improves the patient experience. And it just uses technology that's available to us today. So these are the sorts of things that we need to be bold and just incorporate into our assumptions about how we can operate our businesses.
Yeah, no, absolutely. That sounds great, and I know what you're saying. It's there are simple things out there and technology that's available right now that can make such a difference to people's lives, and in your case, obviously, patients' lives. We're getting into the last sort of 5 minutes or so, Angela, and obviously we've talked about some of the great initiatives and work that you've been doing and are doing right now. I wonder if you can tell me what's on the horizon in terms of. So, I mean, I don't know if you are allowed to give us a sneak peek of what you guys have got planned, but anything you can share would be great.
Well, I mean, there are so many. I mean, one of the things we just launched, we had a partnership. So I just described a couple of things that are commercially available. We do a lot of things where we either co-create with a third party, or we are customer zero of a solution that's not yet commercially available. And so some of those things are stretching into the future, and I'll just give you a couple of quick examples. One example, we partnered with a researcher at MIT to implement an image analysis algorithm that will take a look at a mammography patient's films, digital films, and tell us within a very high degree of accuracy the likelihood of that patient developing breast cancer in the next 4 to 5 years. Now, think about how that changes how we follow up with that patient. Think about how that changes how the patient follows up on his or her own. And that is that's an example of something we're just now launching, but you're going to see that more widely adopted across all of our patients and communities. We last year during COVID, we had a drone program. I mentioned it earlier when we were first talking. We have a partnership with a company called Zipline, and during the COVID shutdown, we worked with the FAA, the North Carolina Department of Transportation, to become the first entity in the U.S. to gain approval, the first entity of any sort. I'm not just talking about healthcare, to gain approval to fly drones over long distances at very high speeds, outside of line of sight, overpopulated areas, and we were flying round trip 30-mile round trip runs for distribution of our PPE and our medicines and other medical supplies. So these are the sorts of things that we were doing during COVID. Now what's on the horizon for that is we're going to start dropping pharmaceuticals at our patients' houses. So that is imminent. We believe it's dependent upon another FAA approval, but we believe that is something we'll be doing certainly before the end of the calendar year. So today in a patient's home, we have advanced sensors that allow you to diagnose your child's ear infection at 10:30 at night. That diagnosis can come in, that prescription can be called in, but you still have to get your crying child into your car and go around the corner. Or for some of our patients, take the crying child on a bus and take 3 buses to get to the nearest pharmacy. Now, what we'll be able to do is in a set of approved routes, we'll be able to airdrop the prescription for the child immediately that night. So these are the sorts of things that are on the horizon that are, I think, going to be pervasive across multiple industries. It's important that in order to adopt things that haven't been done before, that are going to impact your operations, that are going to, move a lot of people's cheese, it's important to have these normal routines and ability to engage with a variety of third parties, a broad ecosystem of third parties, as well as your own thought leaders inside of your own organization that allow you to run tests very quickly on a number of remarkable solution sets that you'll stumble across just very naturally by keeping up with the tech space, and gain real data through experimentation that allow you to justify decisions around major investment. Because you're not going to move the needle in your respective organization unless you have investment in things that are new and you've won the hearts and the minds of the people that have to change their process in order to adopt it. So, I mean, it's just been tremendous lessons learned for us, and I hope that they're useful to your audience members.
No, absolutely. Thank you so much, Angela. We're going to have to bring this session to an end, unfortunately, because we are getting pushed for time. But if anybody does have any further questions for Angela, then you can reach out to her via the app. You can obviously network with Angela. You can network with her directly, ask her some questions. But for now, thank you so much, Angela. Really interesting insight, and great to hear about the amazing work that you're doing over there.
Thanks for having me here today. Very fun.